right now. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Center team, otherwise known as MCTAC, and I'm happy to be here today hosting for our Licensed Behavioral Health Practitioner Medicaid Managed Care Benefit webinar. So I'm going to ask our state partners to advance to the next slide so I can walk through some brief housekeeping logistics before we get started. Okay, great. So just a brief introduction and housekeeping around things for today. We will be posting the slides to mctac.org shortly. I think maybe within the next 15 to 20 minutes while we're in the midst of our webinar today, the slides will be posted. So stay tuned for those. We do ask that everyone chat in any questions you might have throughout the webinar today using the chat function, which is on the right-hand side of your WebEx screen. If you could be sure to chat these questions in and select the option from the drop-down menu that's all panelists, we would just gently request that so that all of our panelists today who are on the call can see the questions that come in. And just as a note, if we're not able to address the questions today, we will work to pull all of the questions together into a document to try and get them answered in the most timely fashion as possible. And for those of you who might be listening to a recording of this at a later date, just a reminder that the information and timelines are current as of today, the date of the recording, which is June 29th, 2017. So with no further ado, I'm going to pass along to our state colleagues to walk us through the content for today's webinar. And I'll just remind them to take themselves off mute if they haven't already.
Okay, thank you. Hi, my name is Justin Timko. I'm with the New York State Office of Mental Health, and I'm going to be walking us through the Licensed Behavioral Health Practitioner benefit. So the Licensed Behavioral Health Practitioner benefit is a Medicaid managed care payment available to mental health clinics for most of their services when delivered off-site in the community. The providers that are eligible for reimbursement under the Licensed Behavioral Health Practitioner benefit are the 599 clinics and Part 598 integrated licensed clinics. I think when I think about making sure that people understand what Licensed Behavioral Health Practitioner benefit is, I think of, first of all, it's a managed care benefit, and it's not a program and it's not a service. And I think initially in discussions with providers or other people about LBHP, there was oftentimes the perception that it was a program or a service, or even that it was an individual, as like an individual practitioner. So I think making clear at the outset that what we're talking about is a managed care benefit, which is a mechanism for reimbursement of off-site clinic services, is important, an important place to start. So additionally, the managed care benefit, LBHP, it doesn't mandate clinics to provide off-site services. This is optional for clinics to provide. I think OMH feels like the off-site services delivered to individuals in the community is a good practice clinically when appropriate. So additionally, one other note is there, of course, is fee-for-service payment available for certain children's off-site services, and that's separate from this managed care benefit, and that fee-for-service payment remains in place. So I'm going to talk a bit about LBHP benefit in terms of eligibility, the services, and the goals or the clinical application of the benefit. So as far as eligibility goes, we're not talking about eligibility for a service, and we're not talking about eligibility for a program. really we're talking about eligibility for reimbursement. So the who, in terms of who's eligible, we're really talking about who is eligible to have their providers reimbursed for providing clinic services off-site or in the community. So the big eligibility, categorical eligibility, I guess, is adults and children enrolled in Medicaid managed care. And that includes HARP or HIV SNP members. And those individuals may or may not be enrolled in a Part 599 clinic. We'll get into a little bit more around the details of what that means later on in the webinar. So aside from the big picture of the categorical eligibility being enrolled in Medicaid managed care, a recipient of off-site services reimbursed through this benefit, there must also meet these clinical and medical factors. So this type of eligibility is really clinical and medical necessity. So we have some examples of what might qualify as clinical symptoms. So we're talking about symptoms like agoraphobia or severe depression or mania, for that matter, delusions, or generally any other behavioral health symptom that might prevent that individual from participating in treatment on-site effectively, I think. Some sort of examples of medical factors that would qualify this person to receive their services off-site and have it reimbursed through LBHP would be the medical, temporary, transitional, or episodic physical symptoms. Now, the types of physical symptoms, probably the best example would be something like a period of post-surgery recovery. Anything, again, that prevents that person from coming to the clinic, something that is prohibitively burdensome, whether it's temporary or permanent, as we'll talk about later on in the slideshow, would qualify them as being able to receive their services off-site and having it reimbursed through LBHP. So this is a list of the reimbursable services that a 599 clinic could deliver off-site and have paid for under LBHP. You can see that the majority of the clinic services are covered when delivered off-site. I think notably in what is covered is the crisis services brief, and crisis brief is a 15-minute unit, and LBHP will reimburse for up to 6 of those brief units per person per day. And you can see what's not covered here are the developmental and psychological testing, and then the longer duration crisis services of complex and per diem. We'll talk a little bit about the clinical goals or the clinical applications of the LBHP benefit. Really, the overall clinical goal is to engage people in services who've not previously participated in clinic services or who have stopped participating or are at risk of withdrawing from treatment. And we sort of talk about these 3 areas that we think would meet that overarching clinical goal. The first one we'll talk about is the engagement. So this will be going out into the community to assess an individual for the need for clinic services, and then to engage that person in treatment off-site with the eventual goal of transitioning them to on-site clinic services, when or if clinically indicated. And again, we'll talk a little bit more about that later on. So another area of clinical goal or application is when there's recurring treatment in providing off-site clinic services in the community. This type of treatment we're just talking about someone who, for some clinical or medical reason, is not able to make progress towards coming into the clinic for services on site. This may or may not be a smaller proportion of people that fall into this category, but I think it's an important portion of the individuals who would be eligible to receive these services. One criteria, I think, for continuing to deliver services on an ongoing basis is that individual needs to continue to demonstrate the clinical and or medical need to be served off-site. Additionally, the clinic has to perform an ongoing evaluation of that need and document the rationale for the delivery of those clinic services off-site on an ongoing basis.
We're saying no audio.
Can people hear this okay?
All good, just keep going. You're fine, don't worry about it.
Thank you. All right. So another clinical goal or clinical application of LBHP is transitioning an individual from an inpatient setting to an outpatient setting. Typically this would be facilitating a new admission or the return of an individual who's already in an outpatient clinic program back to their clinic program in the community. So maybe talk about this in terms of facilitating a warm handoff from an inpatient to an outpatient clinic. So I think there are some significant points to be made about an outpatient provider going to an inpatient unit to deliver services. The first is that we really don't envision this as a way to provide ongoing treatment to an outpatient person in an inpatient setting, or rather a clinic individual in an inpatient setting. This is really about providing transition-type services in the effort to maintain engagement or to facilitate new admission to clinic. The other thing that's important to note is that the inpatient provider has the discretion to permit the delivery of those types of services by outpatient clinic staff on the hospital ground. So clinic staff is going to need to have a conversation with the inpatient providers and sort of talk about what their intention is and ask for permission, essentially, to deliver that service on the unit. So we'll talk a little bit about some rules around the provision of these services that apply primarily to clinic providers. First of all, the documentation of off-site clinic services. So providers must document medical or clinical necessity for the provision of any off-site clinic services in the clinical record of the individual receiving the service. And providers must document the rationale for ongoing off-site clinic services in an individual's treatment plan. All of these documentation and treatment planning requirements are really under the regulatory construct of Part 599. And so this is really the same rules that you have for on-site save the rationale for the recurring off-site clinic services. So again, providers should be complying with the OMH's Part 599 and Part 598 regulations, existing 599 clinic, and the LBHP guidance that has been issued. Additionally, OMH has published an FAQs document on the licensed behavioral health practitioner benefit in support of the guidance document. So substance use services provided in an integrated clinic, a Part 598 clinic, are not covered by this guidance, and you'll need to look at the relevant OASAS guidance established by the New York State Office of Alcohol and Substance Abuse Services. So LBHP does not exempt providers from the necessity of establishing a satellite location when routine and regular visits will be provided at an off-site location. This is an issue that came up a few times in feedback from providers. There was questions about when do I know if I'm providing routine and regular visits, and when am I okay to provide off-site clinic services at a location using the LBHP. You know, you're going to have to take a look at the regulations under 599.5. In that section, there does, I will admit, not super clear explanation of what routine and regular consists of, but you'll find the guidance and the regulations there on what constitute routine and regular services. If you have, sort of agency-specific questions about routine and regular, I think you can also contact OMH's Licensing Bureau of Inspection and Certification and sort of run those questions by them. I think that's an appropriate way to get an answer on some of the specific questions around that. So here are some slides on some of the utilization and managed care related rules. So for prior auth and concurrent review, this is the same again as on-site clinic, Part 599. So managed care organizations must follow prior auth and concurrent review requirements established for Part 599 OMH licensed clinics. So just as on-site clinic, MCOs may not require prior auth for off-site clinic services. MCOs may conduct concurrent review after 30 visits. Now, some point of confusion was, does on-site and off-site clinic services count towards the visit count? And it does. So your clinic visit totals are going to include both your on-site and your off-site clinic services that are delivered. So for reimbursement, the LBHP rate is a reimbursement of the off-site clinic services at 150% of the on-site APG rate. The rate codes that providers will submit for reimbursement are for an Article 31 freestanding clinic, the code is a 1507, and for the Article 28 hospital-based OMH licensed clinic, the rate code is 1519. And these rate codes and off-site APG rates are loaded into the 3M grouper pricer. Another point to make is, if you are billing for the same individual who has received a service from your clinic on-site as well as off-site on the same day, you're going to need to submit separate claims for reimbursement. So there are APG modifier codes that are used with the LBHP claims. These are the Part 599 APG modifier codes. And the managed care organizations will reimburse for the following rate modifiers when applicable: language other than English, after hours, the doc and nurse practitioner, and the reduced services modifier. That is the 40-minute psychotherapy session in a school setting, and I believe, if I'm not mistaken, the 20-minute shortened psychotherapy session as well. So all of these services, just as on-site services, are subject to the state-established multiple service discounting. So we have a slide that has some of our resources on here. This slide is showing us where the LBHP guidance is published on the website, and where our FAQs document is published on our website, and just a link if you have specific questions for clarification on the LBHP benefit or on the FAQs document. You can contact the Managed Care Division at OMH at our email address, omh-managed-care@omh.ny.gov. I think that is the end of our slide presentation, and we're going to open it up to question and answer period.
Thank you, Justin. This is Melissa Stotts, also from the Office of Mental Health Division of Managed Care, and we really wanted to present these slides to you today to give you the background information that's necessary for implementation, but really wanted to start to generate some kinds of ideas about how you might be able to use the benefit once you know the rules in a fashion where you maybe could work with your outpatient provider and your inpatient provider to make connections and things that would just help transition individuals, get them engaged in services, and really looking for some creativity in ways that would make sense for your services and the way you deliver those. So I think that we are going to take some questions at this time, and I don't think we can see what's listed here.
So this is Meg, and I'm happy to kind of go through some of the questions that have come in so far. If I could just ask the state partners to advance one more slide, just so folks could see on top of the wonderful resources that are listed. There's also the MCTAC email address, so if at any point anything comes up, you can feel free to send us questions, as well as the web address where you can go and find this recording, which will be posted probably within the next 24 hours, as well as these slides. So I just wanted to share that before I kind of read through some of the questions that came in. And just to encourage more people, we've gotten a couple questions, but if you want to send us some more, we do have a little bit more time today on the webinar. So first question, let's see here, is I guess someone's asking if it's a duplication of services for a $599 intake assessment provided during an inpatient stay at a 939 psych hospital. Does that make sense to our state partners?
That does. If
not, we
sense.
can go to another question. Okay.
So it's not a duplication of services because this is a managed care benefit, and I think we're thinking of the fee-for-service would be duplication of services.
The question was, is it a duplication of service if an individual is in an inpatient stay and then provider comes in to deliver
an intake? No. So it's not duplication. The hospital would have to let the person in there, the provider in there. This is Gary Weisskopf. They would have to be, for the purposes of transitioning the person to the community, and in fact, because it's managed care companies can choose to pay for the combinations of services, and you don't have an issue that you would have on the fee-for-service side because this is only a managed care benefit. So if the hospital were to agree and the community provider were to come in and meet with the individual to transition them into the community, that would be fine. And in fact, there are 2 hospital systems that we know of that are working with outpatient providers to do that very thing. And it's really one of the things that we're encouraging as a way of helping to get someone who might disappear from care or might not be able to come into care. They can't, for whatever reason, physically or because of their mental illness, make it into a clinic or connect with community care. This is one way to make sure that they continue to get care.
Thanks, Gary.
Yeah.
Okay, next question. Someone is wondering if this would apply to the OMH sustained engagement pre-discharge of initial pre-discharge from inpatient that occurs on the inpatient unit.
Maybe the person, whoever wrote that, could send some more information if they're talking about OMH hospitals on an inpatient setting or if they're talking about something else, because if it's at an OMH hospital for an adult, it would not be Medicaid reimbursable. So whoever wrote that maybe could elaborate a little more on their question.
All right, so if whoever wrote that, if you could just chat us in a little bit more, we'll be happy to try and answer that next question. In the meantime, I'm going to move on to the next one that came in, and this is, in particular, this is about documentation. So this person is wondering if it is okay to document the necessity for off-site services in a progress note when it is a short-term occurrence.
That's the intention, is short-term occurrences would go in an individual's clinical record in a progress note versus more sort of ongoing treatment. We would want to see the rationale in the plan documented in a treatment plan.
So this is Lisa Clark with the Children's Division. I'm just going to kind of add a little bit more clarification to that. If it's an initial assessment, then that wouldn't need to be in a treatment plan because that's something you're going to do as one of your pre-admission visits, so that you can just do the initial assessment the same. All of these services are all delivered in the same manner that you would do them if you were on site in your clinic. So a 90791 is your 45-minute initial assessment. You have to meet all of the same criteria that you would on-site as you're doing off-site. So it's the same thing. An initial assessment doesn't have to be in a treatment plan on-site. It doesn't have to be in one off-site. If you were to go out into the community and you were going to evaluate someone because they hadn't been into the clinic and you were concerned that maybe they were having a crisis and you went to do a home visit, a crisis service is not something that you would be able to anticipate, and no one writes into a treatment plan that you're going to deliver crisis intervention, so that wouldn't be. But if you were to deliver psychotherapy in the home or some other community location because due to their, clinical factors, as Justin pointed out earlier, if they have agoraphobia, they can't come in. If they have some, a physical condition and aren't able to get into the clinic, that would need to be in the treatment plan. You want to write that into a treatment plan, the reason as to why, the rationale why you're going to do a home visit. If you work with children, it's a children's clinic. Any children's provider could write into a treatment plan the need for improved family engagement. So a lot of times you'll want to go to a home, meet with the parents in the home, and also any of us, if you've done community-based service, when you go into someone's home, you learn so much more about the factors that are impacting their treatment, and you can, then it enhances your treatment by going into the home. But write those things into the treatment plan in those cases. So any other normal treatment in the treatment plan, initial assessments, crisis service, could just be in a progress note.
Okay, thank you, Lisa. Our next question is, would it be possible for 599 clinics to conduct an initial assessment off-site on an inpatient setting, perhaps for individuals with symptoms which may make it difficult for them to follow up at the planned treatment setting?
Absolutely, so long as the inpatient setting is willing to let you come in.
I think that we, in fact, this is Doug Ruderman, this is one of the best uses of the service. What we identify is that we lose people when they change settings from inpatient to outpatient. So if you can engage the person while they're still on the inpatient setting, even provide an initial visit on the inpatient setting and then follow that person into the community. We hope that that's going to enhance their participation in the outpatient clinic, and it will really overcome one of the most striking areas where we kind of lose people to contact in that transition.
All right. Thank you, Doug, and thank you, Gary. Our next question, what are the restrictions on using LBHP in a school setting?
That's a really good question. So there, aside from the fact that, the school might have to let you in to begin with, but we're sort of wrestling with this issue right now with regard to if there's already a clinic in there, in the location, a school-based clinic, that could be a problem. So we're really taking a look at whether or not it's really appropriate to have a lot of different providers coming in and out of a school setting. So I think we're going to have to keep talking about that and get back to you on that particular issue, because it raises a lot of complexities that wouldn't exist if you were going to somebody's home necessarily or meeting them in a community setting. So we're going to have conversations and answer that question.
And I just want to add, if any children's clinic providers, they can reach me, lisa.clark@omh.ny.gov, to review that. But what I usually suggest as a rule of thumb, if you have a particular staff person that you are placing at a school like every Wednesday, that's a satellite clinic. Mm-hmm. What we're talking about in using this service is if you happen to have, several clinicians in your main site and they happen to work with particular children, and they may, in each case you have to have a justification as to why for that particular child you are going to go to the school and deliver a service at the school. You may be doing some type of evidence-based practice that's inclusive of the school staff, and it's just for that particular child, then that's fine. Then you can use that as that off-site location.
Right. But the challenge is if there's already a clinic operating in that school, we need to come up with some guidance with regard to that, because you can't necessarily, let's say they're both, you have a kid in managed care who goes to the school-based clinic, and then you have other clinicians coming in to the building, and it adds a level of complexity that we need to come up with an answer for everybody. We recognize that this is a question. So
the school as an issue and the routine and regular.
The school, but routine and regular is easy. School-based, we have to figure out.
Okay. We will make sure to include that on the questions that get sent back to our state partners for further clarification. All right, our next question, when would we want to use this benefit versus the Adult Behavioral Health Home and Community-Based Service, CPST, if someone was eligible for both?
Okay, so that's a really good question. Most people are not eligible for home and community-based services who might benefit from the LBHP service. So you have to be in a HARP to get home and community-based services. You have to be assessed, have a plan of care. Right now, that's done through a health home, and the vast majority of individuals who might be in a community are not going to be in a HARP, but they might still benefit from this service. Additionally, there are places around the state where maybe you don't have enough volume to be able to sustain a CPST program, but you do have a clinic. So there are a lot of places where the big clinic may be, the only game in town. So the clinic could provide an off-site service. So I guess it really depends upon where you are and who the individual would be.
I also just wanted to say that there are components for those people that are CPST eligible. There are components of CPST that can be provided that are not one of the clinic services. So there are like psychiatric rehabilitation services. They're not purely clinical services in CPST. So somebody might benefit from some of those other services that can't be provided by a traditional clinic service.
Right. And for the LBHP, you don't need an assessment. You just need to document the necessity of delivering the service for the individual in the community.
Okay.
I think the most important clarifying factor on LBHP is that it's a reimbursement mechanism for off-site clinic. It is not a service in and of itself. It's what you do on-site at the clinic, only now you're doing it in the community. Only clinics can get reimbursed through LBHP.
That's right.
Okay.
So unlike like CPST where there's other designated providers, this is just specific to clinics.
You might also use LBHP as a bridge if a person's coming out of CPST to a clinic. That's a good time when the person's still enrolled. You can go and do an admission visit and, you know, transition them to clinic as well.
As long as it's under the 3 pre-admission visits by the clinic, because you can't be in both claim clinic and CPST at the same time. But the 3 pre-admission visits of a clinic, you're not yet enrolled in the clinic, so that would be okay.
Okay. Okay, if I move on to the next few questions, state partners, or anything else about that one?
You can move on.
Moving on. All right. So this is a question, I think, about just, again, getting down to the details of documentation. So one of our participants understands that the need for offsite, for the offsite services needs to be documented in the treatment plan, in the TPRs, and the intake assessment. Does it need to be documented any other place in the case record?
When you deliver the service, just like any other, it has to be in the progress note. You're going to need to indicate in the progress note, like any other, the length of time that you spent delivering the service, and then that the location was off-site, which you'll use an off-site rate code.
Okay. Thank you, Lisa.
I think it's fair to say that the same documentation rules apply on-site and off-site, with the extra added piece that you need to justify the rationale for going off-site on an ongoing basis and document it.
Right, that's in the treatment plan. So then when you write the progress note, you're just going to say that you did a home visit for, you know, you provided a 45-minute psychotherapy session at the individual's home. That's all going to be written in that progress note. That's pretty straightforward.
Okay. So our next question, if the services were rendered by a clinic provider at an inpatient setting with approval by the hospital, the place of service code would be the place of service that the clinic uses, correct?
Place of service, you're just going to use your off-site rate code.
Well, there is a place of service code. But we're going to look at the answer to that question and get back to you.
Sounds good. I'll make sure we, okay. Next question, can a 599 clinic provide an intake assessment at a local jail?
No. That one is relatively straightforward, assuming the person's incarcerated, which is, I guess, what the question is. So if the individual is incarcerated, then they're not Medicaid reimbursable while they're behind bars. So I should rephrase that. Yes, you could provide it if the jail lets you in, but no, it's not reimbursable by Medicaid, which I think is what the question actually is.
Yes. Okay. All right, thanks, Gary. Next question, are participants of FIDA plans and Medicaid Advantage plans eligible for these services?
No. This is only for the mainstream Medicaid and for HARPs and the HIV SNPs. And that's the waiver requirement. We got permission to do this under the state's waiver from the federal government, and the waiver only covers those particular plans at this point.
And the next question, I think, is similar in terms of a population that this might be applicable to. So can a nursing home with a large behavioral health population use this service?
Interesting question. I don't think we really thought about it in terms of discharging into the community, which is what I'm going to assume the person is really getting at. Why don't we'll go back and look at that.
But if they're asking about providing services there, I believe in the nursing home rate, they're already
managed care. So the issue is on the discharge side, and that's why I think we need to go back and look at it.
And have them make sure they clarify fully what it is they're looking for. Because if they're looking to provide, I guess because the way that was phrased, a nursing home that has a large behavioral health population makes it sound to me like they're trying to figure out how to deliver ongoing services at a location.
They need to clarify the question, but these are only for discharges when you're at an institution like a hospital that has their own behavioral health services. The idea is really a warm handoff. So please clarify the question and we'll try and get an answer out.
Okay, thank you. Our next question is this benefit available for reimbursement now for adults through only through managed care? And is the same service available for children as fee-for-service reimbursement?
The answer is yes, the Medicaid managed care, it's a Medicaid managed care benefit for adults and children available now. The fee-for-service benefit is the same benefit that existed before, primarily children, and that's paid for with 100% state dollars as it has been for the last few years.
Okay, thank you. Next question is, if an outpatient clinic provides a service at a 939 as part of the warm handoff from inpatient to outpatient, can this be considered a hospital discharge appointment?
Don't know the answer to that.
Is that like a QAR kind of question?
I don't know, because are they talking about, say, a 7-day and 30-day follow-up? So whoever wrote the question, I think you need to clarify what it is you're asking specifically. If you did the appointment in the community and you met the rules for QAR and HEDIS, then it can meet the requirements for follow-up appointments, assuming it's done by a licensed practitioner within the 7 days or the 30 days in the community. And in fact, that's what the hospitals that we know that are partnering with a community provider are intending to achieve, but I'm not sure we understood the question exactly.
Okay, so they actually, let's see, I think they just responded and said yes, the 5 to 7 day follow-up for QAR.
So there's 7 and 30-day follow-ups, and as long as it's done within the time period by the right practitioner.
And the 5-day is just getting an appointment in a clinic within 5 days.
Right, that's important. So the 5-day is an OMH regulation for getting someone who's discharged from inpatient or forensic into your clinic. The 7 and 30 days are managed care performance measurement that's part of the HEDIS measures. So, and yeah, we can put out more guidance
right,
on
but
that.
I just want to clarify, the question is, if you were to have done it on the inpatient unit prior to discharge, would that count?
No.
And it would not. It would have to visit is after discharge as far as the measure is concerned.
Okay. All right, next question. And we've gotten, thank you everyone for, continue to chat in the questions. I know we only have about 10 minutes left, but our MCTAC team will put together these questions and send them to the state partners so that we can try and answer these questions. Whatever we don't get through on the webinar today, we'll try and work with the state partners to put together a frequently asked questions document. All right, so next, if a nursing home resident will be transitioning out of the nursing home, can an Article 31 provide LBHP services with the expectation that the resident or client will be seen in the clinic when released from the nursing home?
Yeah, I mean, so I think we need to go back. We talked about going back and getting an answer on the nursing home question.
Yep.
And that's what we're going to need to do. And the other piece that Doug just brought up is that the individuals have to be in Medicaid managed care. So to the extent that there are a lot of people in nursing homes that are Medicare, Medicaid, and which there are, none of those people will be eligible for this benefit. It's only a straight Medicaid managed care benefit.
Okay.
And HARP, HIV SNP.
Thank you.
And where it would be, if it's applicable, it would be for that initial assessment, not like to start providing psychotherapy on an ongoing basis at the nursing home as you worked towards an eventual discharge as a goal. That would be a misapplication.
All right. Thanks, Gary. Thanks, Doug. Thanks, Lisa. All right. Next question. Can an initial assessment only be provided immediately prior to inpatient discharge?
And that's the idea, is that the person is going to be discharged. I don't know what the word immediately, which I don't know how you would define immediately, but the plan is that the person is going to be discharged and you're there for a warm handoff, and we haven't been more specific than that.
I think you would want it to be just an appropriate, clinically appropriate window between being on the unit and being discharged. You're not going to want to do it the day they get there and they don't get discharged for another 2 weeks or something.
Yeah, and we certainly didn't want to, I think, set a number of days kind of measure, because things happen. And you expect somebody's going to be discharged, and you would come on and do the initial assessment, and then something happens and the person's discharge is delayed by a month. You provided that service in good faith. Everybody anticipated the person would shortly be back in the community. So that's why we didn't want to set days up and say it has to be 7 days before discharge or 10 days before discharge.
There's clinical judgment there. I mean, imminent discharge, and you certainly don't want to do it when this person has not yet been stabilized.
Okay.
Right. Okay. I think there's a question around clarification regarding billing. So if an outpatient clinic is doing the initial assessment while the client is still technically in an inpatient setting, would this billing be denied as a duplication of services?
No. Again, it's only Medicaid managed care, not fee-for-service. Fee-for-service, you would have a problem. Medicaid managed care, you would bill it with the offsite rate code, and you would submit the claim to the plans, and that's the guidance that's been put out. Again, the hospital has to agree with you, that agree to allow you to come in. But it has to really be towards getting the person care in the community.
Okay, thank you, Gary. Another person is wondering how this service will be identified in their EHR, and will it replace the HCBS CPST?
It will be identified with the same procedure codes that you would use in clinic. It's an APG reimbursable service. You would use the offsite rate code, right? And it does not replace any HCBS services. And as Doug pointed out earlier, you can't be getting CPST and clinic services unless this is part of some transition from CPST into clinic.
This is 100% clinic, so it's all your normal clinic coding document. It is clinic, that's all it is. It's just off-site.
The different rate code and a justification for the off-site.
Okay. So a documentation question. The documentation of the need for off-site service, does this need to be documented in a progress note or in advance on the treatment plan?
As we said previously, if it is an initial assessment, then it does not need to be in a treatment plan, the same way as if someone came into your clinic, you're not going to have written a treatment plan yet. So you're going to provide an initial assessment as a pre-admission visit. If you're providing off-site as a crisis intervention, you would not have included that in a treatment plan. If you're providing ongoing, if you're going to deliver psychotherapy in the community in whatever setting, you need to write that into the treatment plan as to what the reason is why you're going to do that.
Thanks, Lisa.
And it pretty much, if you think about it, folks, that guidance is consistent with the same way you would deliver those services on-site or off-site.
Great. So I'm looking through the rest of the questions, and I think at this point we've touched on the majority of the topics that have come in. A couple questions were almost literally some people were on the same page. We had some repeat questions, so I think the best thing to do at this point would be to thank everyone for coming. We are going to relay all the questions that came in to our OMH presenting team, and hopefully we can get some clarification around some of the answers. So again, thank you to our OMH presenter team for presenting this information, and for all of our participants for joining and chatting in your questions. And with that, I don't know if OMH wants to say anything before they sign off, but I think that's the conclusion of our webinar today.
Thank you.
Thanks, everyone.
Bye-bye.